Yeah, so I can show you right now. Let me show you. So now it's recording. So then share screen is what you can do. Press this button. And then you click this. Hello, welcome to PathDoctorMD. I'm here. I'm your host, Dr. Lacey, with my festie bestie, Dr. Ahmed. Today we're going to be talking about salivary gland lesions. This is a weakness of mine, and he's going to teach me. So buckle up, sit down, and enjoy the show.
So salivary gland neoplasms, generally, if you have a resection, making a diagnosis, in most cases, it's not that hard, but
If you have a resection of a salivary gland lesion,
correct,
it's not hard to make a diagnosis.
correct.
Okay.
However, if you have like a biopsy, like a small biopsy, it becomes extremely challenging because a lot of these neoplasms, they can look similar.
Why?
Because you have entities like, for example, pleomorphic adenoma. It's called pleomorphic, and it's called pleomorphic because it can look like a lot of other stuff.
Okay.
Also, some of these neoplasms can have some sort of metaplasia. For example, you can have like a clear cell carcinoma, or you can have like an oncocytoma clear cell variant, and both of them, they can look similar.
Okay. So salivary gland lesions they look similar.
Yeah, they can look similar.
And on resection is fine because you have the resection, but on
Yeah.
biopsy, it could be difficult because you may get a part of the pleomorphic adenoma that looks like a
Yeah.
low-grade oncocytic tumor.
Yeah, for example.
Yeah.
Yeah.
Okay.
Yeah. Yeah. So how do we approach these lesions? Some people classify these into basaloid neoplasms,
Basaloid neoplasms. Okay.
which they
Oh,
look blue from low
basaloid
power,
neoplasms. Okay.
like basal cell adenoma, adenoid
Yeah,
cystic.
they look blue. Are they palisading?
They can show some
Because
palisading.
when I think of basaloid, I don't necessarily think of blue. I think of palisading.
Oh, not necessarily.
Not necessarily palisading,
Yeah.
but blue, those cells. Okay.
Yeah.
Okay.
You can have oncocytic, and the oncocytic ones, they have these cells with rounded nuclei, prominent nucleoli, abundant eosinophilic cytoplasm, low NC ratio.
But those wouldn't be basaloid.
Yeah, this will be called oncocytic, for
Okay.
example.
Okay. Oh,
Like,
I cut you off. So yeah, go ahead. Sorry.
so you can classify, some people classify them into, you have basaloid neoplasms, including this and this and that
Sure.
entity. You can have
And
oncocytic
oncocytic is another. Okay,
neoplasms,
I like
which
this.
include this entity, this entity, this entity.
Like a Warthin's tumor would be oncocytic.
Yeah, oncocytoma would be oncocytic.
Oncocytoma would be oncocytic. Okay.
Yeah. So there are multiple ways to classify these salivary gland neoplasms, and we're not going to go into that today. What we're going to focus on is, if you have a small biopsy, how are you going to approach that biopsy? So you can use that approach. For example, if it looks oncocytic, then you're going to consider oncocytoma, you're going to consider Warthin tumor, you're going to consider some other entities that can look oncocytic. However, if you have a small, tiny biopsy, sometimes it gets very tricky. So the approach that I'm going to follow here is that, and this is something I learned from one of my best friends, Carl.
Is this his information?
Yes.
Is this his notes?
Yes.
He created this.
Yes. He taught me this.
He taught you this.
I was writing
His
down.
name, and you were writing this down.
Yes.
So can we? Oh, is this a document? This is a document that you have used. Can you write the
Yes.
person's name here?
Yes.
You know, you have to give credit where credit is due. And I didn't know. I honestly, I was a bit skeptical of this information that he was about to teach me.
Yes.
Okay, perfect. So Carl is one of your besties.
Yes.
He did a pediatric pathology fellowship and he is in Canada right now.
Yes.
So thank you, Carl. I'm about to learn
Carl.
this. Okay.
So yeah, the approach that I learned from him is that these salivary gland neoplasms, you can divide them into S100 positive neoplasms and S100 negative neoplasms.
Okay, so you told me about the basaloid versus oncocytic. Are we ignoring that now?
For now, yes.
Okay. And
Yeah,
this is specifically for biopsies.
Yes.
Okay.
You can use that for a resection, but usually on resections, making a diagnosis would be much easier than making that on a biopsy. And you can still use this algorithm.
Okay, I see. I'm following. Now it's making more sense, the case that you were telling me about, how you got to the S100 part of it.
Yeah.
Okay.
Yeah, so for these lesions, you can think of salivary gland neoplasms as some of them that are S100 positive, and then some of them are S100 negative.
Sure.
So that's the first thing.
So which ones are which?
So we do have a list here.
Mm.
So S100 positive include neoplasms like secretory, carcinoma, or the one that previously was called mammary analog secretory carcinoma.
Hot water's right behind you.
Okay.
Okay, so secretory carcinoma, so that's a big scary one.
Yes.
Basal cell adenoma. Basal cell adenoma looks basaloid with peripheral palisading, and it has blue cells. Polymorphous adenocarcinoma, peripheral adenocarcinoma. Those are low grade. That's a low grade lesion, right?
Yeah.
And it's polymorphous, not pleomorphic, but polymorphous because it has different architectures.
Yeah.
I forget. And then adenoid cystic carcinoma. That one has all the little punched out circles in it, right?
Yeah.
Okay. PA carcinoma, pleomorphic adenoma or carcinoma X pleomorphic adenoma. So that's going to be the one with the like cartilage ish, the ducts. And then how do we define pleomorphic adenoma?
So pleomorphic adenoma, you want to see two population of cells, and that's what I'm going to get into. But
Oh, am I cutting you off?
so let's
Oh.
let's see the approach first, and then let's take it from there.
Oh, I see. Okay, you're right.
Yeah.
Yeah, this is good. I'm sorry for
Oh, that's
interrupting
okay.
you.
So if you have a small biopsy, you do the S100, and then if it's S100 positive, you think of these entities, and
Sure.
it's not an exhaustive list that
Sure.
includes everything, but it includes the common things. And then if it's S100 negative, then you include these entities.
Okay.
So that's the first thing. Is it S100 positive or negative?
So are we disregarding histology
For now, yes.
in this mental exercise?
Yeah, this is just a mental
Okay,
exercise for
okay,
now.
okay, okay.
And then after that, how many types of cells do we have? Do we have
This would really confuse me the other day.
because you can have epithelial cells.
Ductal cells.
You can have
Those are epithelial.
these are epithelial, and then you can have myoepithelial cells as
Sure.
well. And then there are other entities that have additional cells, for example, mucoepidermoid carcinoma.
They have 3 different types of cells.
Yeah, you have epithelial, you have squamous cells, you have what they call intermediate cells, and they have mucocytes.
And the mucocytes, yeah.
Yeah. But for this exercise, S100 positive or negative? That's the first question. The second question, do we have just epithelial component, just myoepithelial component, or do we have a combination of epithelial and myoepithelial component? And sometimes, for example, myoepithelioma is composed predominantly or almost entirely of myoepithelial cells.
Okay, so that would be a 1-cell type lesion.
Yes.
Okay.
On the other hand, you have pleomorphic adenoma, you have epithelial cells that form ducts, and you have myoepithelial cells. So you have two populations of cells.
Which one was that one?
Pleomorphic adenoma,
Okay.
right? You have epithelial or duct forming cells, which are epithelial cells.
Yeah.
And you have myoepithelial cells as well.
Sure.
Right? So sometimes it's really hard on morphology to decide whether the whole thing is epithelial, the whole thing is myoepithelial, or if you have combination of both. Because myoepithelial cells, they have so many morphologies. They can look epithelioid, they can look
We had that spindle
plasmacytoid,
one.
they can look spindle cell, they can look stellate, they can have like clear cell morphology. They have so many morphologies that sometimes it becomes really challenging to decide whether on the biopsy that you have, whether it's just epithelial cells or it's just myoepithelial cells or it's a combination of both epithelial and myoepithelial cells. So that becomes challenging sometimes. So one of the stains, if you can't decide morphologically, you can't see, you don't know what you're looking at.
Okay, hold on. This is just such a unique and interesting approach that I haven't learned before, and I'm just having a hard time wrapping my head around it. So if you get a biopsy of a salivary gland, say parotid gland biopsy.
Yes.
You're doing this workup for why? Like
if I can't decide what this lesion is, because sometimes they can look similar to each other, and then I have a differential diagnosis, and I can't decide whether I'm going to call this entity, this neoplasm that I'm having, this entity or that entity. If I look at the thing.
Okay, so for instance.
Yes.
If I have something that to my eye it's a biopsy, it looks like a Wharton tumor.
Yeah.
But it's like instead of having the nice cystic spaces, it's all collapsed. So it's just like all these layers of Wharton tumor, like granular eosinophilic cytoplasm, benign looking cells. And then not much else. So it just almost from this like view, it looks like just sheets of benign but eosinophilically granular cytoplasm. And so I'm like, is it a Warthin's tumor, or is it an oncocytoma?
Yeah, in that case, the distinction is not gonna matter that much.
Okay, so okay, so that almost helps with answering my question, because is this algorithm helping me get to a distinction that helps when it matters?
Yes.
Okay. Okay. I'm buckled up.
Okay. So if you can't decide, then you can use a stain to see if you have epithelial component, and the stain that you can use, for example, is CK7.
Okay.
And then
Sure.
you can use a myoepithelial stain to decide whether you have myoepithelial cells or not. An example for that, for example, would be p63 stain. So if I'm looking at a salivary gland neoplasm, I feel like I'm walking in the dark. I don't know what I'm looking at. The differential include any entity in the salivary gland neoplasm. In that case, I would do S100, CK7, and P63. If S100 is positive, I'm going to think about these entities here.
Yeah.
If S100 negative, then I'm going to think about these entities here.
Okay.
If just one population, so secretory carcinoma, one type of cell, just epithelial component. So it's going to be positive. It's not going to be positive for P63 because it doesn't have any myoepithelial cells. Basal cell adenoma has epithelial and myoepithelial component, so it's going to be positive for an epithelial marker like CK7 and myoepithelial marker like P63.
Oh, so in other words, this types of cell
Yes,
is going to be cells that you can identify using IHC.
yes. Polymorphous adenocarcinoma and adenocystic carcinoma, they can look very similar to each other. But as you can see here,
And they're both
polymorphous,
S100 positive.
yes, but polymorphous is one population of cell, while adenocystic.
Oh, I think I'm following. Okay,
Yeah.
so then if we're in between two things that look alike, and you're
Yes.
telling me polymorphous adenocarcinoma and adenoid cystic carcinoma look like,
Yeah.
that checks out to me. And they're both S100 positive.
Yeah.
Now it's like, okay, now in addition to the S100 positive, that broke it up from other things that we
Yeah.
weren't really even thinking about, but just for this algorithm.
Yeah.
Now if we want to decide, are these one cell population or are they two?
Mm.
You're telling me that we can, in addition to our S100, we can also order
Yeah.
p63 and CK7.
Mm.
And if it's polymorphous adenocarcinoma, it will only light up with CK7 and not p63. Or do I have that backwards?
So polymorphous adenocarcinoma is going to be positive. That gets more
Do you
complicated.
see where I'm at?
Yeah, I see where
Okay.
you're at.
Do I need to take a step back?
Yeah, what I'm saying for the purpose of this discussion for now is that do you have one population or two population, and the utility of using an epithelial and myoepithelial marker to get into these diagnoses, but then there are other things that we can do. But for the purpose of this discussion for now is that polymorphous has one population of cell, adenocystic has two
Okay, can
populations.
we go over the populations of cells? Because I don't, it's like for secretory carcinoma on the very first one,
Yes,
that population of cells is epithelial cells.
yes,
Because they're from the secretory ducts.
yes,
Okay, the next one, basal cell adenoma.
yes.
This is going to be basal cells.
They call it basal cell adenoma because you have these basaloid cells with the peripheral palisading and all that thing. That's why they call it basal cell adenoma.
So
It
what?
doesn't have anything from where it comes from.
So for basal cell adenoma, is it going to be epithelial and myoepithelial? Okay, that's I think that's what I'm trying to ask. For polymorphous, that one, so for secretory carcinoma, it's epithelial. For
Yeah.
basal cell adenoma, it's epithelial and myoepithelial.
Yeah.
For polymorphous, what's that one cell type? Is that epithelial? Is it CK7 positive, or is it going to be a myoepithelial positive?
So the thing that I know about polymorphous is it's P63 positive but P40 negative compared to adenoid cystic, and that's what we use to differentiate it from adenoid cystic.
P40 or P63
It's P63
positive?
positive, P40 negative.
Okay, that's helpful. And then adenoid cystic carcinoma, is it epithelial and myoepithelial as well?
Yeah, and it's P63 positive and P40 positive.
I see. So then this gets really to the nitty gritty with
Yeah.
the types of cells.
Yeah.
Only except this one doesn't have epithelial cells, the polymorphous one, right? If we're just doing,
I'll have to double check that.
because then I think this is when you were telling me about this algorithm that you used the other day, and
Yeah.
I was going through in my own studies. He has a lot more experience with salivary gland neoplasms than I have, and I'm a skeptic at heart anyway. And so when I was going through this, I was caught up by the number of types of cells in each of these entities.
Mm,
And so this, I think, is helping me understand, because obviously for secretory carcinoma,
yeah.
you have epithelial cells, but you also have mesenchymal cells, and you also have like you have mesenchymal stromal cells, mesenchymal endothelial cells. Like there's vessels supplying this thing, so you don't
Wow.
just have one type of of cell. Let's see, what are we pulling up?
Polymorphous adenocarcinoma pathology outlines. Let's see. I want to see if they're describing
You
the
want to read
cells.
the microscopic? Let's see, what does it say?
Let's see. Cytological.
One type of tumor cells, monotonous pale nuclei, marked chromatin clearing, resembling that of papillary thyroid carcinoma. I did not know that.
Yeah, me too. But as you can see here, composed entirely of
One type, and they look like PTC. What is this, polymorphous?
polymorphous adenocarcinoma.
Oh, that's interesting.
Yeah. And then they had this entity cribriform adenocarcinoma, but it says here it's currently considered by the WHO classification as a variant of polymorphous adenocarcinoma.
And I think you had that in your
Yeah.
chart. Can we look at a picture real quick, and then
Yeah.
and then we'll go back to it?
This morphology to me is adenoid cystic.
No, this is adenoid. This side is adenoid cystic to
Yeah,
me.
to me it's this side. But regardless, the whole thing looks like an adenoid cystic. But according to what they say here, this turned out to be a cribriform uh adenocarcinoma, which is a variant of polymorphous adenocarcinoma. And it's
Well,
cystic.
and
So that's what I'm trying to say, is that everything can look like everything in the salivary gland neoplasm.
yeah, that's what
There is a lot of morphologic overlap, and that's why doing stains
so
would be
CK7
helpful.
would be.
So CK7 positive, P63, they said variably
78 to
positive.
100 is pretty high. Sometimes we
That-
call that positive in entities at 78
Yeah.
to 100%.
Yeah, but P40 is negative.
Okay, so P40 is negative and polymorphous, and that is
Yeah,
really useful information for me.
yeah.
Okay, awesome. Thank you. Let's go back to our chart.
Where's our chart? It's here. Okay. So yeah, and then you have myoepithelioma and myoepithelial carcinoma. They are composed almost entirely of myoepithelial cells.
Checks out.
Epithelial, myoepithelial carcinoma, you have an epithelial component and myoepithelial component.
2 cell types.
And then cyaloblastoma is a pediatric lesion.
Can we look at a
that has
picture of that?
cyaloblastoma, sure.
Yeah, look at you.
No, it's glitching.
There we are.
Cyaloblastoma.
Oh, nest of basaloid cells, ductules and solid organoid. What?
Oh.
Will you go back to the microscopic description?
Okay. Let me just figure out how to maximize this.
So
No.
everything in green, I think, is just what you're sharing, but I don't know. I did not know you could do that. That's pretty cool. Hold on, let's just go back really quick. Because the microscopic said ductules and organoid nests of basaloid cells with fine chromatin and cuboidal epithelial cells. And then this, cyaloblastoma.
Nests of basaloid cells with vesicular chromatin.
This looks like glomus tumor to me.
Yeah, it does.
You know, at some point
It does.
you just have to.
It does.
It's difficult.
But that's beyond the scope of our discussion today. What we're discussing is this out there.
Sorry, you're gonna stay on focus.
Yes.
Okay, so that was a cyaloblastoma. It looked to me like a glomus tumor. I just wanted to see if it was.
Yeah, and the S100 negatives. Oncocytoma, most people think that oncocytoma is just the oncocytic cells, which is one population, but you do actually have an epithelial and myoepithelial component.
Oh,
Warthin tumor similarly has epithelial and myoepithelial component, so two populations. And in addition to that, you have a lot of lymphoid cells, right? Mucoepidermoid carcinoma, you have the mucocytes, you have these squamoid cells or squamous cells, and you have intermediate cells. Hyalinizing clear cell carcinoma, one population of cells.
I don't know that one. Can we look at a picture of that? What does that
Yes.
look like? Hyalinizing clear cell carcinoma. Is it high grade?
It's a translocation tumor.
Wait,
I don't know if it's high grade or not.
go to the other side. Whoa, what? Yeah, maximize interval screen.
Yeah.
Yay.
Right.
And then go back to now you're in the browser. Yeah. Okay.
Yeah.
Carcinoma.
That's not.
I'm actually an ambassador for pathologyoutlines.com. And let me put in a plug for them. They're doing great stuff. If you want to be an ambassador, just reach out to them. All you have to do is update your institution's residency list every year.
Yeah. So highly nice.
Oh, can I microscopic? I need to see the words first.
Okay.
Monomorphic cells with clear or eosinophilic cytoplasm arranged in anastomosing nest, trabeculate, or cords. Two stroma types. You can have dense hypocellular hyalinized tissue juxtaposed to a desmoplastic stroma that may appear myxoid. It's virtually pathognomonic. What? Two stroma types, dense hypocellular hyalinized tissue juxtaposed. Ooh, I think you're throwing with their mouse. Do you read like that with your mouse?
For our followers.
Hold on. Okay, hold on. Let me read it for myself. Two stroma types. And what is the name of this entity?
Hyalinizing clear cell carcinoma.
Hyalinizing clear cell carcinoma. Two stroma types. Dense hypocellular hyalinized tissue. That checks out. That's in the name. Against desmoplastic stroma. And the desmoplastic stroma may appear myxoid, which it usually does. Oh, so it's just desmoplasia plus hyaline. What are these cells then? What are these cells? I guess the first line was monomorphic, so
Yeah.
clear. Can I see some more pictures?
And you can have mucinous differentiation in up to 50%. So as you can see, everything can look like anything.
Can you go through some pictures?
Yeah.
Normal.
Mm.
Right?
Yeah.
Is this the hyalinizing part?
Yeah.
Is this the hyalinizing part?
Yeah.
Is this the clear cell part?
Yeah.
Okay. This is the hyalinizing part?
Yeah.
That's a nerve. I don't know.
I don't think
Is this a nerve?
I don't think so.
This is hyalinizing part. I definitely think that. And then this is the clear cell part. Okay, what does it look like on? This also looks like a glomus tumor.
Yeah.
Does it not? Does it not? Except for I feel like glomus tumors, the nuclei would be dead center in all of these. Huh. I was expecting something different. Is this a like a deadly salivary gland lesion?
I guess we can see. We can go back. I don't think so.
It doesn't seem like it is. It seems kind of low grade-ish.
Mm.
But I really don't know because this is probably my 100th time hearing of it, but really the first time I'm actually hearing about it. I feel like I haven't really heard about it until just now. Hyalinizing clear cell. Do you have a prognosis? Usually at the top. Prognosis. No form of organics, low grade, local recurrence, necrosis, polymyelitis. Okay, cool. Rare high grade. That's cool. So that was polymorph. No, that was hyalinized. Hyalinizing clear cell. Okay.
And then you can have like salivary duct carcinoma and lymphoepithelial carcinoma. So what I'm trying to say is that if you have a small biopsy and then you can't decide what's happening, in that case, what you can do, you can throw an S100, CK7, and p63, and then take it from there with the addition of the morphology.
Okay, so let me repeat that back. If you get a biopsy of salivary gland lesion,
Yes.
and it looks histologically similar to a couple of different things, as we've discussed, a lot of these look similar, even though we didn't look at pictures of all of them.
Yeah.
Then you can order 3 stains to start off with. You can do an S100,
Yeah.
you could do a CK7,
Yeah.
and you could do a P63.
Yep.
A S100 is going to be highlighted in half of these salivary gland tumors, as is seen in this chart here. CK7 is going to highlight a cell population that is epithelial, and a P63 is going to highlight a cell population that is myoepithelial.
Yeah.
And the types of cells in this column, like here, where you see one type of cell, it doesn't necessarily mean it's either epithelial or myoepithelial. It just means that there's one population of cells that can be highlighted by one of these stains. Is that correct?
No.
Okay, correct me.
It means that one here is either epithelial or myoepithelial. If you have two, then you have epithelial and myoepithelial.
Yeah.
Yeah.
So if it's a 1, is it always epithelial?
Not necessarily.
Yeah.
ESL,
I know. He's ESL. That's why it is what it is. But I think
Yeah.
I think that's what I was trying to say.
I see.
So I guess however it was said was not one that it still seemed wrong to you. But I think
Yes.
I might have said it wrong. But yeah, so once you're looking at the histology under the microscope, the S100 helps you, and then furthermore, these stains will help you identify which
Yeah.
which cells are which, and also if there's more than one cell population, obviously two of these cells will be lighting up.
Yeah.
So that's our lecture. I feel like that's a good stopping point. I wish I understood these actual entities a bit more, but I think that this is good for especially understanding your flow.
Yeah.
Thanks to Carl, Dr.
Carl's the
Carl.
best.
Yeah, Dr. Carl, the pathologist, and what part of Canada is he in?
Vancouver.
In Vancouver, Canada. I will keep y'all posted on how I use this. I know that he has used this. Do you want to share the case?
Yeah. We had a case 2 days ago. We looked at it. I was pretty confident that it was on cytology. We get the core. I was very confident on
What
the
did it look microscopically?
so on the cytology smear. It looked under the diff quick, it looked like an oncocytic neoplasm, meaning I saw these cells that have perfectly rounded nuclei, prominent nucleoli, abundant eosinophilic cytoplasm. So at that point, I was like, oh yeah, this looks like an oncocytic lesion. And then we looked at the core, and then on the core, it looked to me like an oncocytoma. But I was under the impression that because we do have a biopsy to call it just a low-grade oncocytic tumor
Yeah.
and give a differential
Yeah.
diagnosis.
He described it to me microscopically, and I was like, that sounds like
Yeah.
an oncocytoma.
Yeah, on the differential favor oncocytoma, but say that Warthin tumor because maybe we're not sampling the part that has the lymphoid tissue, and then maybe it's oncocytic carcinoma. The only difference or the way by which we can differentiate oncocytoma from oncocytic carcinoma is if you have like capsular invasion. But obviously, because we have a small tiny biopsy, you can't decide that. Oncocytic carcinomas also have like polymorphism, necrosis, all these things.
But it
But
was
then
you described it as a low grade
yeah, it looked like a low
oncocytic
grade. Yeah.
neoplasm.
That's why I was willing to call it
Yeah.
to favor
Yeah.
oncocytoma.
Can't rule out Warthin's tumor because
Yeah.
it's only just a small representation of the
Yeah.
rest of it. Can't rule out, even though this microscopic specimen doesn't look like oncocytic carcinoma,
Yeah.
we can't rule out that it's not oncocytic
Yeah.
carcinoma elsewhere in the lesion. So
Yeah.
that's how that was signed out. And then what happened with the stains?
And then before I also why did I want to order stains? Because one of the oncocytic lesions is secretory carcinoma. And morphologically, it didn't look like secretory carcinoma to me. However, I've had a couple of salivary gland neoplasms that I was thinking something and they turned out to be
I have
something
too.
else.
Yeah.
And because of that, now I have a pretty low threshold to do stains when I'm kind of
So that's a good example for oncocytoma versus secretory carcinoma for the S100. Like that's literally the line's number one.
Exactly. That's what I was thinking is that I'm going to do S100. If it's positive, then I could think of one of these entities with secretory carcinoma being on top. But if it's negative, it's going to make me more comfortable calling this an oncocytoma.
And then what? And I was like, and I argued with him, and I was like, why would you even waste the time ordering the S100? Because it looks, acts, talks, and walks and quacks like a duck.
Yeah.
Like it's a duck. Like it's a duck. It's an oncocytoma. Be done with it. Do go say oncocytic tumor cannot rule out, higher grade version of it. And then he knows this algorithm, and so he's doing the S100, thinking, what if it is secretory carcinoma? Why not? Why not if there's, and we had a good discussion, like if there's a stain, to make sure it's not something like there are we won't go into too many details here, but there are times which in this one, to him, he felt strongly what was one of those times. So he does this, and we're both trying to be attendings. We're both literally learning. We're trying to learn exactly what to do as an attending, as opposed to just like whatever we were doing prior to. And so he tells me that he orders the S100. And I'm like, okay, yeah. So now you'll be able to know for sure that it's not secretory carcinoma. That's the worst thing it could be. And then the next day, the S100 comes out, and he tells me that it's
before the S100, I also did CK7 and p63 because I wanted to know
Your
if
flow.
just one population or is
Yeah.
it just two population of cells. And then I look at the S100, and even without using the microscope, the S100 is
Completely
diffusely
positive.
positive.
So
And
that's
that's why I'm like, no, it's not an
it's not
oncocytoma. It's
oncocytoma.
not. It's not.
Not.
I was so
I
confident
was
it's an
too.
oncocytoma. The
I didn't
first
even
stain that
see
I
it.
looked at, it was not an
So as
oncocytoma.
soon as he saw the S100, he was like, "This is
Yeah.
this is not an oncocytoma." And so then he goes to his other stains, and
Yeah.
he's like, "Okay, is it one cell population or two cell?"
Yeah, and the
population?"
CK7 was positive in subset of the cells, but not all of the cells. And the p63 was positive in a different subset of the cells.
So
So
that's two cell populations, myoepithelial and epithelial.
yes.
And so then what did you do next? Because I love this part of the story.
And then I came back to this algorithm. I was like, oh, it's S100 positive, so I'm here. And then is it one population or it's two population? So it's not secretory, it's not polymorphous, it's not myopithelial carcinoma, it's not a cialoblastoma. It was
Not
like a
in a kid,
45
yeah.
or 50-year-old patient. It was an old patient, so it's not a cialoblastoma. So my options were basal cell adenoma,
Which you did.
option number
Okay,
one,
sure.
but it didn't look like basal cell adenoma to me because it's not blue, it's
Yeah, you
acidic.
described it as pink. Yeah.
Yeah. And then it didn't look like adenocystic carcinoma to me because to me, adenocystic, I want to see the cribriform.
Yeah, you did
I
not
want to
describe any
see,
punched out
yeah.
spaces.
There's so many things that I
So
want to see
then,
adenocystic that I didn't see.
so
And
then,
even on the imaging, they were like, oh yeah, well circumscribed lesion, 3 centimeter, whatever. So now we said it's not secretory, it's not basal cell, it's not polymorphous, it's not adenocystic. PA is still on the differential. It's not myoepithelioma or myoepithelial
there's two cell
carcinoma.
populations.
And the only
What
other
do you think this
possibility,
DMC stand for?
myoepithelial carcinoma.
Oh, no, it's not high grade enough,
It's
but I
not high
guess it could
grade.
still be.
And to me, myoepithelial carcinoma, you have the epithelial component lined by the myoepithelial component. But the case that I had is you have the epithelial component here and the myoepithelial component here. It's not the myoepithelial component lining the epithelial component.
Okay,
So
sure.
the only possibility for me to call based on this
On
algorithm was
histology, re-looking at histology
yes,
using these stains and this algorithm. Thank you, Carl.
yes. The only thing that I can think of is the pleomorphic adenoma.
So then what did you do?
And then we ordered plague stain, and then the plague stain was diffusely positive, so that made it a pleomorphic.
And that's why we decided to sit down and do this recording
Yes.
because honestly, I wasn't fault. I didn't even, I'm a suspect. I'm a suspicious, maybe not a suspect, but I'm a suspicious, pessimistic person. And you tell me this algorithm, it wasn't checking out to me, but that is such a great example of why this algorithm is important and why we decided to sit down to learn you. I hope that you all have enjoyed this wonderful teaching session with Dr. Ahmed and Dr. Lacey. We will see you on the flippy flip.
Bye.
Don't forget to like and subscribe.
Bye.